some basic principles of patient management with lines and leads. First, you always want to wash your hands prior to patient care. Assess lines, leads, tubes, and drains in a clockwise fashion. Make sure you pull the covers back and off the bed so you can see everything attached to the patient. Trace the lines and leads. Make sure you trace them all the way back to the source. Untangle them as you go and secure them prior to mobility. Ensure you know the purpose of the line, lead, tube, and drain for optimal safety. Unplug devices that can be unplugged, such as the IV pump, and ensure the cords are secure and not hanging on the floor or a fall hazard. Move all lines to the side of the bed that you plan to exit. And remember, some lines may be disconnected prior to mobility. You want to set everything up before your patient stands to maximize safety so the patient can be closely guarded. So for instance, you may hang the Foley catheter on the walker, you may secure the oxygen tank on the IV pole, etc. You want to make sure you plan the route, ensure there's no obstacles, and plan for seated breaks if needed. Sometimes I'll follow the patient with a chair, or I may place chairs strategically in the hallway. Ensure there's no lines between you and the patient, and that no lines will be dislodged in the event of a loss of balance or fall. Consider any extra help that may be needed to manage the lines, such as a nurse, a respiratory therapist, a perfusionist, and define roles and responsibilities of each team member. And lastly, advocate for alternate catheter location if mobility is prohibited. So maybe consider having the femoral location move to an axillary location if that's something the team can do. And this will be dependent on your facility policy. Now, let's take a look at a patient with a lot of various lines and leads and tubes and drains, and let's see how you may properly set up a patient for mobility. When you enter a patient's hospital room and you're ready to mobilize, you want to make sure you first check the lines and leads in a systematic fashion. So I always recommend going clockwise. I start at the head, I go all the way down one side of the body and up the other side of the body until I get back to the head. So if we start with this patient at the head, the first thing we come across here at the nose is the NG tube. So this is an NG tube, and remember, this could be attached to a feeding tube monitor. It also could be attached to suction if it's draining gastrointestinal contents. Before you mobilize a patient, you want to make sure you secure this, because if gravity were to pull on this, it could pull on the patient's nose. So you could tape it, you could pin it, or lots of times people may tuck it in the pocket here to keep it secure during mobility as well. The next thing we encounter here in the patient's mouth is the endotracheal tube, or ET tube. This indicates that the patient is intubated, and this would be attached to a ventilator. To mobilize this patient, you would likely need the help of a respiratory therapist as well. If we continue to go around in a clockwise fashion, you always want to make sure you're pulling back covers, pulling back gowns, and checking your patient's skin and what's under the gown as well. So if we're looking under this patient's gown, we see our EKG leads. This patient happens to have a 5-lead EKG that's color-coded. This particular one is great because I have an easy way to remember it. White on right, so the white is on the right side of the body. And then I remember snow over grass, so that's white over green. Smoke over fire, so that's black over red, and then the brown's in the middle. When a patient has an EKG lead, there's always going to be a wire because the heart rhythm's being monitored. Lots of times this wire will be filtered through the patient's pocket, and then this will be leading up to a hemodynamic monitor. If it's got a portable unit here attached to it, you can either put it in the pocket or you can just leave this out and bring a portable monitor along with you. Now, if I continue to go around this patient clockwise, the next thing I encounter here is this bandage. If I were to trace what's coming out of this bandage, there is this tube that's leading down to this. So this is the chest tube, and this is the atrium or collection chamber. So the important thing with this is you want to make sure you keep it upright. It's measuring content that's being drained, and if you tip it, that's going to affect the measurements. You can turn this to the side for mobility and attach it with these hangers to a walker or to the side of the bed. You just want to make sure when you're finished with mobility that you turn this back out to set it down so it doesn't tip. The other important thing is to make sure you keep this below the level of insertion because it's using gravity to drain. Sometimes these are connected to suction, and if so, you would need to bring a portable suction with you. If I continue to go down in a systematic clockwise fashion, the next thing I come across here in the brachial region is an IV line. And I know this is a peripheral IV, number one, because this line is flexible and spongy. And if I trace it, this line is coming over here through the IV pump and out to this bag here. So the important thing when it's going through an IV pump is you want to remember not to raise or lower this pole, because this is at a certain rate of infusion. If you raise or lower the pole, it can actually change the rate of infusion. So you want to make sure you check with a nurse before you do that. Now, the other thing I come across next is this, which is my pulse oximeter. So this is measuring your patient's oxygen saturation levels. This will usually be attached either to the hemodynamic monitor or possibly to a portable pulse oximeter device. Now, I want to continue to pull my gown up and check discreetly my patient's groin, nothing here. I'm going to continue to come around in a clockwise fashion here. I don't see anything in the feet or legs. So if I continue to come up this side of the body, the next thing I see is this tube here. If I trace this tube down, I come across this, which is a rectal tube or a fecal management system, which is draining bowel contents. Again, I want to make sure I keep this below the level of the rectum so it can properly drain and not get backed up into the patient's system. Systematically, the next tube I come across is this one. So this is my Foley catheter. If you can see here, this has been secured with tape. This is very important because you want to make sure this is not pulling on the patient during mobility. Sometimes there will be another kind of stat lock system that keeps it secure. But if I trace this line down, it comes to here, the Foley catheter. So you want to make sure this stays at least 18 inches below the bladder so it can properly drain. If for some reason you do need to move one of these tubes up and over to the other side for mobility, that's okay, but you first want to make sure you drain this, any urine that's in the tube down into the bag, so that again, that it doesn't back up into the patient, which could possibly cause an infection. Okay, if I continue to go up in my systematic fashion, I'm checking the groin here, no lines in the groin. But here is another drain. So if you see here, we have a surgical drain. This one specifically is a JP or Jackson Pratt drain. So these are typically not secured in any formal way, but if you can see, this one has a safety pin so that it can be attached to the gown prior to mobility. You want to make sure it's attached below the site of insertion so it properly drains. And also you want to make sure it's not pulling on the patient. So you could tape it, pin it. You just want to make sure it's secured in some type of way. If I continue to go up my side of the body here, the next thing I encounter is here in the radial region. So this is different than the IV because I can feel it's kind of stiff. And if I trace it up, so I have this line, I'm going to continue to trace it. I come across this here. So this is a transducer. So this would be an arterial line that constantly measures blood pressure. In order for the blood pressure to be accurate, this transducer needs to be at the level of the right atrium or the level of the heart. This is not attached to anything currently, but this would be the wire that's going to the hemodynamic monitor that's actually giving you the blood pressure reading. And then, because we have a line that's monitoring or giving us a reading, we're going to have a transducer and a pressure bag. So with the pressure bag, you always want to make sure there's enough pressure in it to maintain the patency of the line. So there's an indicator here, which if I pull this out, you can see there is a green line here. You want to make sure this is pumped up to the level of the green line before you mobilize a patient. And you always want to check that continuously anyway. And lots of times it should already be on the green if the nurse is monitoring it closely, but it's a good thing to check prior to mobility. Now, if I continue to come up this patient, the last thing I'm going to encounter here is this central venous catheter. So remember, this is a line that can have multiple functions. It can be putting something in. You could potentially do a blood draw from this, and it could also be attached to a monitor for a central venous pressure to give you a reading. If it were attached to a central venous pressure reading, then you would also have a transducer and a pressure bag for this line as well. You want to make sure this line is secure prior to mobility, so you can see this one is secured nicely with tape. If you were to see that this were loose or coming undone, you want to make sure it's re-secured prior to getting this patient up. So that is how you check the leads in a clockwise systematic fashion before mobility. Now, before you mobilize this patient, you do want to make sure you get all your lines and leads to one side of the bed and that you unplug any devices that can be unplugged. So for the IV pump, it does run on a battery, so you can unplug it and secure it neatly here so this cord is not a fall hazard. For things like the chest tube and the Foley catheter and the rectal tube, I usually bring them all to the side of the bed, but also I put them up toward the head of the bed because when I'm mobilizing my patient, I don't want to have to worry about the lines and leads. I want to be able to focus on them, keep them safe, and make them feel comfortable. So I'm going to put all my lines up toward the head of the bed here. That way, when I sit this patient up on the side of the bed, all my lines are neatly right here so I can focus on the patient and not have to worry about my lines. Now my patient is ready to mobilize.